All right. Good afternoon. It's always kind of being the last speaker in a meeting is always a difficult position to be, but experience has taught me that I always have the minimum number of slides that I need to have at this stage of the day, because obviously we don't want to keep you for too long, and we don't want to keep you from the workshop as well. And in fact, this presentation is really about thinking about preparing one of the workshops as well, because I will present one of the interventions that we've been thinking about and getting some initial feedback from you. So I'm Domenico Giacco. Yes, I'm both an academic. I work at the University of Warwick, but I'm also a clinician within the NHS. And oops, it doesn't go further. Oh, it does. Okay. I mean, other colleagues have very eloquently made the point about how much we need more provision. There is obviously historically stigma has kept quite a lot of people from getting care, and still we have quite a lot of people who don't get the care that they receive. This is true for people with mild to moderate mental health difficulties, but also for people with severe mental health difficulties. So we need intervention that are able to reach both these groups of people. Mental health services still at the current level of provision can be seen as very much overstretched. And AI models can expand the reach and benefit of intervention. This is things that lots of people have said today before me, and obviously the idea there is also that we need to have accessibility to care as well. Lots of people don't like to access care 9 to 5. Lots of people find it easier to access care in a way that is more private. They don't want to talk to things with other people and so on. So AI in theory has got quite a lot of potential benefit to provide this kind of care. But the important point is that providing things via AI-assisted model doesn't mean that we don't provide evidence-based models. So the therapeutic principle has to be evidence-based, and then the AI can be a delivery for it. And also there are questions as to how you integrate those models with everything else that goes on into services. So we are focusing for one of the case studies on a model that has a very established evidence base. This is called Dialog Plus. The journey of this model started more than 20 years ago. It's kind of, I wasn't involved then, but then I, in a way, a dwarf on the shoulder of giants who have developed this model. And this model is based on principles that come from quality of life research on how you communicate effectively with patients. In fact, it was a model that came out to structure the clinical communication with patients in order to make it therapeutically effective. And also a type of psychotherapy called solution-focused therapy, which is a very simple, goal-focused kind of therapy that can be easily studied in research and maybe delivered with a limited level of training. And this intervention, Dialog Plus, when delivered by clinicians, has improved health outcomes. It has done so in trials in the UK. It has done so in trials with people with schizophrenia in Europe, across different European countries. It has done so in trials on people with severe depression in Asia, in trials with people with severe anxiety in Africa. So it's been tried with different populations and in different continents, and has always found to be something that helped either quality of life or reduce the level of depressive symptoms. So there is an evidence-based when delivered by clinician, which is quite clear. And one could say it's robust to being delivered in different settings, which is not the case for a number of interventions. Of course, you need to have some adaptation. Most recently, we have tried it in schools. So we tried with people with children in schools who we train teachers to deliver Dialog Plus. And these obviously children will have mild to moderate mental health difficulties, and even then it helped. So it's a very generic intervention. It was developed for the more severe end of people with mental health difficulties, people who are diagnosed with schizophrenia, with psychotic disorders, but it's proved adaptable to other groups. And the next slides will be about presenting how it looks like. So people do through different steps. We are trying to think about what are the steps of the intervention. I mean, we have a manual that describes these steps, but we're also kind of trying to increase the number of steps to try and really specify how to deliver it through a chatbot. The first step is that patients rate their satisfaction with various life domains and treatment aspects. So if you see these scales, ask the patient to rate from 1 to 7, and each of the number has a label attached to it, so people know what each number means. And this is important for two things, actually for three things. One is that as you do the intervention, you also get outcome data. You'll be surprised, but this is what people in mental health service are most excited about, because they always have the problem how you evaluate what you do. And you can really look, the second advantage is that it's not only mental health data, it's also physical health, job situation, accommodation, and so on. So you get an idea about quality of life across different domains, which sometimes when we really do our reviews of mental health in our clinics, we do focus on symptoms, medications, whilst this looks at the patients throughout. And the third, and therapeutically the most relevant benefit, is that then the patient can compare where they are now with where they were in the previous session, but also they can decide what to talk about. So lots of people, I'm sure you have heard about talking about patient-centered care and how we should ensure patient-centered care. This approach enables patient-centered care by design, because it starts from a self-assessment and it enables the patient to choose what to talk about. Now, the following steps are about the solution focus approach. Once someone selects, for example, job situation as a problem, then they are led through a 4-step solution focused therapy informed approach. The first step, for example, if you look at this person who has rated job situation as 3, I'm just making an hypothetical case now, just for us to understand how the intervention works. So this person, you ask them, why did you put down 3? And because I'm not really satisfied with my job situation. I don't have a job at the moment. And then the next question you ask is, or the chatbot might ask, is why is it 3 and not 1? What is working at the moment? So you see, it's very positively framed, kind of starting to work on strengths. And the idea is, okay, I'm not really happy with not having a job, but at least I have kind of some benefits, so I can kind of financially get well, but I'm not really happy with that either. And then the next question is, what would it be like if it was 7? What would it be like if it was everything perfect? And the person might say, maybe I have a job, full-time, good salary, and so on. And then the final question is, how can we go, keeping in mind 7, how can we go from 3 to 4? So it's a very, very simple kind of approach, but has proved transformative in terms of improving quality of life in different contexts. And again, like people can choose what to talk, so it becomes patient-centered. People have an actionable kind of way of looking at things, and people can see how things improve over time. So it provides also positive reinforcement. So this, as simple as this approach is, we felt having to train clinician, and we have trained clinician more or less everywhere in the world. But if you only think about the NHS, there are 10 trusts in the NHS in which this is the standard mechanism for care planning. So people, when they care plan, like when the patients does a joint care planning for the future with their care coordinator, this is the kind of intervention this is based on. This provides not only an advantage in terms of making care planning based on an evidence-based approach, but also it provides routine data, which means that we've got now data for, we have collected for 12,000 patients, but in theory we could have it for 500,000 patients that we could benchmark the intervention against. Now the next challenge is how we can make this intervention available to people, even if they be discharged by a service, or even if they want to look at it outside of the usual care planning kind of meetings and so on. And AI provides an opportunity for that. So the idea will be to develop a dialogue system that helps without the need for a clinician, helps the patient do the step 1, like asking questions. Sometimes patients cannot just go through this kind of list. They have to be supported, ask the question, led through it. Then helps them choose what they want to address, and helps lead them through this easy kind of, not easy, it's still challenging, as a lot of you who have experience of doing therapy might appreciate. But how can the chatbot lead people through this 4-step approach? And this is the idea. We have tried it with kind of some more kind of off-the-shelf models, and it looks like these kind of models are able to to do it, but we want to develop a very well kind of tailored and particularly independent model so that obviously we look at data in the most safety possible, friendly possible way, and also we develop something that people don't have to pay to access, particularly if they have severe mental health conditions. Right. So this is the next step, and this is what we will be talking about maybe in one of the workshops, how we can make this intervention developed by a chatbot, and what do you think we need to think about for people to have a good experience of it and to make the most benefit from it. I think this is my last slide, so I promised it would be very long.
Thanks very much.
Okay.
So I have a question in terms of, which is, I think, nice for helping us with the discussions in the workshop. What do you think is particularly important in how this, like the dialogue system, should guide this interaction, and where do you also see some of the challenges in that?
Okay, yeah, I think there are many things that are important. When we did our preliminary kind of engagement work, which was mainly with students, so it was like more alpha testing, there were a couple of things that we weren't really kind of, we hadn't thought about. For example, if we could be delivered in different languages, that helps people, because you don't have that within the services. So if you could kind of converse with the dialogue system in your own language, it's actually something that would add to people's experience. The other things that also was really interesting to me as kind of someone who also does kind of interactions with patients in a clinical life, is that sometimes they were really frustrated that the response will come very fast. So if you come speak of very kind of heavy kind of issues with the therapist, they naturally would sort of reflect about it and come back to you a bit later. And actually the system would always respond very fast to whatever you kind of basically throw at it, which is not very lifelike. And finally, the idea is that you need to have a little bit of pre-contemplation stage. Sometimes like a generic system pushes to action, whilst you need to have a little bit of people helping them to sort of talk about the issue, empathy, and then going into an action. So it's a number of things that are a bit technical, but also have a very strong kind of therapeutic grounding, which I think that's why it's so exciting to work together with different people with different expertise and to see whether we as therapists think is important can be put in practice within the dialogue system. Yeah.
Okay,
there is someone.
I'm thinking practically where you have a highly motivated patient and they're interested in doing this.
And that's in a way why this simple approach was developed, because what we found in our clinics at the time was, okay, people see what they need to change in their life, but they have this, particularly people with schizophrenia, they have some specific type of symptoms called negative symptoms, which are very much about deficit, motivational deficit, and so on. So that is why kind of attaching to the solution focus, kind of giving some kind of practical kind of anchors for people to think about, like, where are you 3, and then can you go from 3 to 4? These kind of things provide that kind of behavioral activation mechanism for people to streamline the task that they think about, and to think about, if I want to do this, if I want to find, I mean, in the previous kind of example, if I want to find a voluntary job just to occupy some of my time, who could help me with that? How can my professional help me with that? How can my family member help me with that? What can I do myself? So the challenge of all of this is going from a point in which the professional prescribes to the person what to do, to get the person to a point in which they are on the driving seat and can actually design the action themselves with this kind of model. And then the professional becomes an helper rather than someone who prescribes you to do things. So it is obviously a challenge with some patients, but having trialed it with people with schizophrenia across different kind of samples, we have seen that we can get at least a moderate effect size in terms of improving quality of life items across different contexts. So it's something that has worked. So solution-focused therapy is really about going from looking at what's the situation now and getting to a point in which we have better scores on the items. So it makes it very practical, which some people who struggle with motivation find it a bit easier to streamline rather than going for big kind of goals, if that makes sense.
What would be a moderate effect size?
A moderate effect size means that at least 3 items of that scale that you've seen improve. Yeah. So that means, yeah.
Yes, thank you very much. I wanted to ask, is there a predetermined point in the interaction, in the, where you would refer that person to actually see a therapist?
I think it wouldn't, the scale wouldn't help you to decide whether it's time to see a therapist because it's a quality of life scale. But you could have within the chatbot some kind of red flags in terms of
Yes,
risk for suicide and so on. So we purposely don't look at deficits within this scale. We look at life areas and we want to improve the individual life areas. Now we think about that this intervention improves 3 life areas in the life of people who have chronic psychosis. It's a rather big effect for people because people with severe mental health difficulties can get stuck for a very long time with very poor kind of quality of life in specific parts of their life. So it's rather than just improving symptoms, it changes aspects of life. So it's not about really managing risk. It's not about really improving symptoms. It's really about changing aspects of life that are relevant to the person. But yeah, I mean, if there is something coming up in terms of risk, so we have tried with the system as well to say, what if people want to get kind of advice on how to get drugs or advice on how to harm themselves? And the system seems to be solid to sort of deal with that, providing access to support rather than kind of going along with what the person would want. Obviously, it was just trying to challenge the system. So it goes in the wrong way, but the system seems solid to that. Yeah.
Thank you.
Yeah.
There's one more question here. Was it you? Okay, here you go.
It's really interesting to see, Domenico. So the question, one of the things that the clinicians do in those interactions is they kind of negotiate with the patient what the question means and what the numbers mean on the scale. Did you see any of that going on with the preliminary interactions you did?
Yeah, I mean, it's one of the first thing that you get is it is one thing about the problem, but I mean, the main issue that you find, particularly we work with people with the severe end of mental health difficulties, is that would say, I don't know what to do. Right, so I don't know what to do about it. It's like if you say, what would bring you from 2 to 3? People that don't really question what is 2 and what is 3. They will normally say, I don't know how to change, right? So the way in which you try and do that is trying to think about, okay, giving 2 or 3 options. Like, does this work for you? Oh, and then the next one, does it work for you? Like you can generate some ideas, but the challenge is that generating ideas without making people feel that they have to follow those ideas. So that's I think the main challenge with language. They don't go in terms of, oh, I don't know what's very dissatisfied thing or mildly dissatisfied means. You see what I mean? They don't really challenge that. What they challenge is, I don't know what to do about it. So that's the main challenge with getting people to change. Yeah.
Thank you. Hi there. I just wondered about the areas of difficulty that you have, like job and practical help, etc. How often are people coming and saying their main presenting difficulty isn't on that list?
How often do they do that? Well, if this scale comes from something called Lancashire Quality of Life Scale, and that was then shortened into something that is a bit kind of shorter than that. So in a way, it does cover quite a lot of things that we identified as main areas of life in previous research. That's why I say it comes from quality of life research. Say that if you go into schools, we don't talk to them about practical help. So sometimes if you go into different, so like this is the main kind of the trademark one is the one done with people with schizophrenia, people with severe depression. If you go into different groups of people, you will have to think about what really matters to them in terms of life area. So you see that lots of the research coming that generated that list comes from schizophrenia. But when we had to do that in schools, we have to go into schools and ask people, does it make sense to you, or do you want to go for something different? So you have, the approach would be still the same, but sometimes the topic, depending on the group of people, can change.